Good afternoon on the East Coast, good morning on the West Coast, and good evening in points beyond. I'm Joel Hellman. I'm Dean of the School of Foreign Service, and I want to welcome you to the first of our SFS Fast Break discussions of this academic new year. The students are on campus, our faculty are back from their summer work, and of course, we've got a lot of urgent issues to be covered through our Fast Break format. You know, it is said that a public health architecture and infrastructure works best when we don't know it exists. Well, certainly over the last few days and weeks, you surely knew it exists. It is on the minds of everyone. High-profile conversation yesterday on the Hill, major sort of moves that are making headlines. And of course, we want to bring our expertise from Georgetown and the School of Foreign Service to the fast-breaking news that's happening around the world. And we couldn't be happier to have Dr. Rebecca Katz with us. She's a professor here at Georgetown and director of the Center for Global Health, Science, and Security. Unusually, for those of you who think that SFS stands for Safe from Science, she is a joint appointment between SFS and our medical center, Georgetown University Medical Center. She teaches in our STIA program, Science, Technology, and International Affairs, our Security Studies program, as well as the Global Infectious Disease program. And she's had a long career at George Washington University before she came here. And she has played a major role in the global governance of public health emergencies around the world. She's an author of over 100 peer-reviewed manuscripts, 5 books. And she has worked in a truly nonpartisan way for many, many years across many global crises. And here in the United States, she was working in the State Department for over 15 years across multiple administrations. But it is important to recognize that she has also played a very specific role in the COVID-19 response, where she worked in the Department of State as a senior advisor and as an advisor to President Biden's team on these issues. So these are not debates when we have these one-on-one discussions, and I want to make sure that everyone knows her background and her prior experience in this. But we will begin to try to make sense of what's going on, and I'm going to try really hard in this conversation to bring it down to a practicalities of what does this mean, and how is it impacting the provision of health services in the United States, abroad, surveillance issues, and so forth. So let me begin with the biggest question. So what's actually happening? We've read so much about it, heard so much about it. Can you give us the overview of what you think is happening, essentially, to our public health architecture, in particular the CDC, but beyond?
Um, yeah, well, I'll do my best. Dean Hellman, really appreciate the opportunity to be here and to talk with you about this, and for everybody's interest in what's going on. I mean, the last 9 months have been a bit of a challenging time for public health in the United States and around the world. And the last 24 hours have been tumultuous, including Robert F. Kennedy Jr.'s testimony on the Hill yesterday. So what we have been seeing, so there is clearly new leadership from the Trump administration at HHS, including at NIH, FDA. There was new leadership at CDC, the reduction in force efforts by DOJ, the dismantling of most foreign assistance in health as part of the $9 billion clawback. There was the announcement on the first day of the administration to leave the World Health Organization. There was the White House pocket rescission package that was put forward last week to propose canceling $45 million in appropriations to the Pan American Health Organization. And there was the announcement to not provide the previously pledged $1.58 billion to Gavi, which provides childhood immunizations around the world. Over the last couple months, on June 9th, all 17 technically qualified sitting members of the Advisory Committee on Immunization Practice, ACIP, were removed. These members were replaced by some known vaccine skeptics, which raised a bunch of questions about how this committee would evaluate scientific evidence moving forward. 2 months later, on August 5th, HHS announced the move away from supporting all mRNA research. On August 8th, just a couple days later, CDC was targeted in a violent attack that left 500 shell casings and bullet holes on campus. It killed a police officer. And this violence, which was potentially fueled by anti-vaccine disinformation, was met with kind of a non-response by government leadership, which really which caused a lot of consternation on the part of the public health community and the CDC employees specifically. And then last week on August 27th, Dr. Susan Menares, who had only just been confirmed as the CDC director, was removed from leadership for, in her own words, and this is from her Wall Street Journal editorial yesterday, her removal was due to not following instructions to ignore evidence. And then several senior leaders were then immediately resigned, noting the inability to do their jobs in the current political environment. So all this has left us in a situation where the official process for vaccine recommendations and approvals has changed. Who can get access to certain vaccines, including COVID vaccines. This directly impacts not only what insurance will pay for, but also the approximately 50% of children in the United States who receive their vaccines through the Vaccines for Children program. So if ACIP, for example, says no to measles vaccines, that's 50% of children in the US who will not get it. Now that has not happened yet. So, but this is just kind of the scenario that we're starting to play through. We've seen massive cuts that have led to dramatically reduced disease surveillance and response capacity at CDC. So when Texas was in the midst of an unprecedented measles outbreak, CDC was kind of noticeably absent from the traditional role that they would have played in guiding the outbreak. When Milwaukee officials in April requested assistance from CDC to investigate an outbreak of lead poisoning in public schools, CDC, for the first time in 70 years, denied assistance because the CDC childhood lead program had been eliminated and all of its staff had been fired. And then today, so as of, I believe, this morning, a new Ebola outbreak has been confirmed in the DRC. As of yesterday, there were 28 suspected cases, 15 deaths, including some healthcare workers. Some really kind of cool advancements in that the genomic sequence was posted within 24 hours. So we know that this outbreak is actually due to a new spillover event. But CDC is not currently communicating with the World Health Organization or instituting surveillance at borders or issuing health alert notices. So there's a lot happening, and even just trying to keep track of what some of the political decisions mean for our day-to-day existence in a world where, as you say, we as public health professionals are working best when nobody knows what we're doing. So it's keeping track of all of this and then trying to map the political decisions to how this impacts all of our lives it's a lot.
Well, look, can you, to get a little bit even more granular
Yeah.
in the implications of these events for, kind of specific instances of challenges and threats to us? Take the Ebola as one example. Can you go a little bit further in what would you normally expect to see? You've lived through many of these crises yourself. What would you normally expect to see? What's not happening, and what are the implications or perhaps reactions from others who are trying to adjust to changes in their response?
I mean, I think on the international scale, my understanding is we are still communicating bilaterally with our partners around the world. So there's probably, even with the reduction in force and a much smaller footprint at CDC, there's still probably communication that's happening directly between CDC and our partners in country. But as you know, all the funding for assistance was pulled back. So a lot of what we would have otherwise been doing in terms of bringing medical supplies and support and epidemiologic capacity and lab capacity is dramatically reduced. We're not communicating directly with the World Health Organization, so we're not using those multilateral channels to coordinate with global partners on how to coordinate a response. At the in past administrations, the interagency plan when you have an Ebola outbreak would be to enhance surveillance and response activities at the border. So any flight coming in directly or indirectly from an affected region would have been met by people who would, provide information and set up surveillance activities and help help people monitor any symptom development. That's not happening. Health alert notices would have gone out to hospitals around the country to be on the lookout for specific symptoms, particularly in people who might have had a recent history of travel. I don't know if that's happening. So a lot of the kind of the day-to-day response activities are just dramatically reduced in capacity.
And tell us what that means here in U.S. Health policy and what's happening, perhaps even at at your local health system. You and I were talking about here. We're both residents of Washington D.C. MedStar. You are an employee at the medical center, and you are ensconced in the MedStar system. How is MedStar, for example, trying to think about responding to these changes in the overall response and CDC support in these issues?
Yeah. I mean, I think that there's a MedStar, like a lot of other hospital systems around the country, are trying to figure out, one, how to actually truly identify what the impact is, because it's not always a direct impact, right? So MedStar in Washington, for example, will communicate directly with the DC Department of Health, but the DC Department of Health relies on CDC for their kind of backstopping and official information. So one, it's really trying to figure out what is the day-to-day impact. And then there's a lot of, everyone's trying to scramble a little bit to figure out, okay, what do we actually need to do and what capacities do we need to be able to do this? Do we need to be recreating our own health intelligence? So there are a bunch of civil society groups around the country who are trying to basically create their own disease surveillance networks and post that information in a public way. We're trying to think through what are some of the non-invasive surveillance activities that could be supported by non-governmental entities. So things like wastewater surveillance. Are we rolling that out so we have better situational awareness of diseases in a community? Are we doing our own health alert networks? Are we changing our risk profiles, but doing that in a way that doesn't, we're always kind of relied on the subject matter experts at CDC who were the best in the world. And now it's really hard because you're not, even though some of them are still there, you're still not sure if the information that they're providing is being politicized, which is hard. It's really hard.
Well, a note to our listeners, I'm going to start incorporating into the conversation questions that come through the Q&A function or the chat function. I won't be identifying specific questioners, but I'll be trying to bring them into the conversation. And one thing I know you're working on, and a question did raise, which is, what about Georgetown, and what about yourself and others in the team to actually kind of respond to this in some way, in a way that private foundations have in other parts of the agenda? What are you seeing on that front?
Well, I mean, even before we get to Georgetown, what we're starting to see right now is a response from, again, domestically by different states, right? So there was an announcement this week that California, Washington, and Oregon were forming their own coalition. They were going to basically try to recreate CDC for the West Coast. Other states reacting to some of the changes that are happening at CDC, particularly in ACIP, are starting to change their laws. So I believe there's, I mean, it gets really weedy, but really important to think about the law and governance of this, because the actions that this vaccine group takes at CDC have a lot of kind of knock-on effects. So if that committee at CDC says we don't think that anybody should be getting their Hep B shot anymore, that means that there are a lot of laws at the state level that tie directly to that will say things like, well, then a pharmacist can't give out Hep B shots anymore, or we're not going to support, giving out that shot to kids who receive it through Medicaid or through other kind of assistance programs. So what you're now seeing is some of the states trying to get in front of that a little bit. New York yesterday, I believe, is signing an executive order to allow pharmacists to administer COVID vaccines to anybody who requests them, even if ACIP doesn't say so. Massachusetts is taking similar action. So we're trying to actually in real time monitor some of those changes that are happening. to see how this plays out. There's something called the Strategic National Stockpile, which was where you went to for your mask and respirators and access to certain drugs and vaccines. But the administration recently announced that it's only going to cover items in that stockpile that are related to chemical, biological, or radiological events. And what that means is it's not going to stockpile things that you would use to respond to, say, influenza. So now states are starting to think about, well, should we have our own stockpile? But how do we think about that? So we're trying to, we in our research center are trying to figure out how do we support all of these entities that are popping up when, you know, not everybody has expertise in all of these spaces, and they often probably would have relied on the experts in CDC to help them with this. So trying to kind of recreate some of those expertise. So working on that, we're also trying to think creatively around what are innovative ways that we not only finance public health, but also what the role of the private sector could be. So if you are a private sector entity that hosts what we'll call mass gathering events, right? So you run an arena or a concert series or whatever it is that you're bringing a lot of people together, is there a way to support some of these organizations to do their own non-invasive surveillance, where normally they would have just relied on the public health community to do that for them? But is there a way for them to do that themselves, to be able to pay for that in a way that supports their own customers and their own, bottom line for their business, but also in a way that backstops the public system and supports it and ensures that data are shared for kind of collective well-being? So again, there's a lot of moving parts, but trying to figure out how do we work in this new normal?
Well, actually, given the fact that there are a lot of moving parts, and as you say, those moving parts are moving in very different directions at the state level, certainly, and the private sector, what are the possible coordinating mechanisms, as one questioner has asked, to kind of make the most of the potentially positive role, obviously, that the
Yeah.
private sector can play, private foundations can play, and of these very, very different state responses, which we all know these public these diseases do not follow state boundaries. So what kind of coordination is possible in the absence of strong CDC leadership?
Well, I think that's the challenge, and that's the piece that's really concerning. So we saw this at the beginning of COVID in early 2020, when there wasn't an aggressive federal response. What you saw was every state, and sometimes groups of state, trying to it was a little bit like the Wild West. Everyone was trying to get access to their own masks and their own stuff, and they lost their purchasing power. And states were competing against other states to be able to get access to tests, right? I mean, it was unwieldy, and I think that showed the challenge, what happens when you don't have something coordinating all of this. So I think that there's probably an opportunity for the National Governors Association to come together and try to organize some of this. If the private sector is going to take a much more active role, is that something that the chambers of commerce can do? So I think that there are ways to start thinking about how to do this in an organized fashion. We're also seeing some of the professional associations band together. So like the American Academy of Pediatrics, for example, you might have a decision coming out of CDC that seems to be more political than evidence-based. And then you have a separate ruling or a separate decree from some of the professionals associations saying, well, actually, we've looked at the evidence and this is what we say. Now that gets really confusing for people, because you now have a lot of different streams of information, I think the really critical role that the federal government has always played is being kind of the arbitrator of all that information, to be able to say, okay, yes, there's 1,000 different research articles on this. We've put them all together. This is what we say, and this is what we believe. And now we're entering a space where that that's not as trusted by a lot of different partners as it was before. And that means that you now have all these other groups that are popping up. And there may be an opportunity for some of those groups to come together in a more unified way. But that's kind of, time will tell on that.
Well, can you tell us what, maybe it came into the testimony yesterday, 3 hours, I didn't watch the whole thing, but how, Kennedy has obviously, he has put in some acting leadership in the CDC. He has a very strong kind of health agenda. He talks about the need to really restructure and rethink CDC. What can you tell us, or what do you know about the architecture that he's trying to put in place as an alternative to what has been lost? What is his vision of the change that he wants to see in CDC? And is he grasping the nettle to say, I'm starting to make that change?
Yeah, and I don't actually know. I feel like things are changing so quickly. And in fact, I think somebody in the chat, there may even be chatter right now about whether he'll still be in power within the next 24 hours, given the amount of momentum and and how the hearing went yesterday. I think it's there is he has in his past statements talked a lot about issues around, how to make people in general healthy. And there was a lot of thinking around, the initial moves around food dyes and how do we make our food supply more safe. And so I don't know so much about organizing the CDC, but the kind of the shift in focus. But that shift in focus has also meant shutting down some really critical aspects of the organization. Like I said, the lead poisoning group gone. A lot of folks who did occupational safety were let go, and then some of them were brought back. There does seem to continue to be an emphasis on maintaining the team that focuses on high consequence infectious diseases, and the biosafety level 4 laboratory is still operating. I check in regularly with the individual that runs that to make sure that it's continuing to operate. So I think those capacities remain, but it's really uncertain, and it's really uncertain how many people will stay. I think it has been really difficult for the people who work at the organization, and how they feel like they've been treated by the administration, and kind of lack of support they felt from the general public as well. It's been very difficult to kind of continue going to work every day.
Is there been a collective response from those former CDC staff? Are they going anywhere in particular? Are they coordinating among themselves? Because you did have a coordinated high-level effort on the part of major, players in the CDC. Are they regrouping to try to create a shadow organization somewhere else? What are you seeing among that group of officials? Many of whom, incidentally, as you had said earlier, many of whom supported strong aspects of Kennedy's own agenda.
Yeah, we haven't seen what we've seen is a um organization around advocacy. So, this week, 1,000 HHS employees signed a letter, and put, civil servants putting their name on a letter calling for the resignation of the HHS secretary is a lot. So we've seen a lot of coordination on the advocacy side. We've seen groups like Defending Public Health, which was stood up by a professor at Yale, and has lots of people who have organized around that. You're seeing groups like Mike Osterholm in Minnesota put together a group that's been trying to provide expertise and analysis related to vaccines. Our own Jesse Goodman has been doing something very similar. So you're seeing these groups kind of pop up and trying to have a voice, but there hasn't been a single unified entity that's, CDC in exile, or whatever it would be called. And I think I think that there are efforts to try to see what can be done, but trying to do that at scale is really hard. I mean, I will tell you that we have I support a center that we stood up at MedStar that links between MedStar and Georgetown University Medical Center, that is trying to figure out, can we mount like a rapid response team that could work in as a force multiplier for some of the states and locals that are having their own budgets slashed, right? But trying to do and figuring out how to do that, how to support it, how to provide a space, and how to finance that is somewhat complicated.
Well, look, in the last few minutes, I really want to focus on, and there have been a couple of questions that have come throughout the chat in the sort of why, why and where next, um, because obviously there are the personal views of Kennedy
Mhm.
himself, but there's obviously also a deeper problem in the level of trust, and one can say that distrust was stoked politically, but nevertheless, it's there. There is a sense of now deep distrust in the information that had been provided or has been being has is being provided. So the question is sort of what seems to be driving this level of distrust. It's obviously a function of the dramatic sort of shifts in people's lives associated with COVID. But how do you start to even rebuild trust? Thinking some people, someone asked what happens after Kennedy. How the trust issue is not going to go away anytime soon. How do you start to think about dealing with the fundamental issues of trust that may be underlying this broad sort of shift in the way we're handling these issues?
Yeah, I mean, it is a huge, huge question. There has been so, in addition to everybody in the world's experience with COVID and how the experience manifested for yourself, for your families, um, there's also been a tremendous amount of mis and disinformation. And there hasn't been a great response to it. It's hard to combat the mis and disinformation that's been put forward. And initially the response was, well, just your doctors will say, we'll talk to you, but that's not the same as kind of a coordinated approach and trying to get at kind of the core, not only the core reasons behind it, but then also how to address it. Now, that is not my area of expertise, and I have some wonderful colleagues who are working really hard, not only to understand the root causes of this, but also to figure out what some of the mitigation aspects are. But I will say, but in the interim, I fear that it's going to be a lot of individual experiences that actually, unfortunately, get at some of those misinformation challenges, right? So we are now cutting back the capacity to do food safety in the country. Well, if you start having more foodborne illnesses, you might actually be like, wait a second, I wish that happened. The state of Florida announced that they're going to get rid of vaccine mandates. Now, there's some that they can get rid of through an announcement. Some are going to have to go through their state legislative branch. But if they are able to actually get rid of MMR vaccine, measles, mumps, and rubella vaccines for incoming school children, that's going to have significant ripple effects, which is going to really, I say it up front, public health is when you don't know it exists. But when you start seeing things happen to your economy, to your community, to your international relations, to all sorts of other aspects due to some of these policy decisions, it's going to impact the way individuals start to sort through some of this information in their head. I will tell you that I spent all morning on WhatsApps with international colleagues, who are just scratching their heads around what's happening on the vaccine front and saying things like, well, maybe we all change, the vaccine requirement forms we have for any American who wants to come visit us in Europe or Asia or right, like that. There are real implications for some of the things that are happening.
Well, look, we have to stop there. There's much we could discuss, but the ending on the point of recognizing the implications that it has for all of us, internationally, nationally, in our own communities, is really vital, I think, to understand at this stage of the game. Look, thank you for giving us more context, however brief it might be, but a little bit more than we've had before we started, and get a sense of what this means and how sort of significant it is for global public health research, for monitoring, for disease control, based on your experience. We really appreciate you taking the time to be with us. And of course, we appreciate all of you from our broader SFS audience around the world for tuning in. We will continue over the course of the next several weeks. And I'm sure we will have many occasions to have fast break discussions in these fast moving times. So thank you very much. Good to see you all. And thank you, Dr. Katz.
Thank you so much.